joining us. My name is Chris Collins, and I'm President and CEO of Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria. Welcome to this dialogue on women's and maternal health during a pandemic. Friends is engaged in advancing issues around women's and mothers' health as part of our advocacy and research on responses to AIDS, TB, and malaria and emerging pandemics. And women's health is, of course, a critical issue for women themselves, but also the health and welfare of whole communities and societies. And COVID-19 has presented major new challenges to women's health. So we want to talk about that. Today, we're going to look at how COVID-19 has impacted maternal and women's health globally, best practices and challenges for governments, the private sector, and civil society in responding to that and serving women's health. What makes partnerships most effective in long-standing and emerging pandemics? I want to say a very big thanks to our Chief Policy Officer, Mark Lagon, for spearheading this event for Friends. Mark is going to introduce our tremendous panelists, and he'll moderate the discussion. But I also want to say a very special thank you to all our great panelists. Thanks for being with us today. Mark, over to you.
Thank you, Chris. Women's and maternal health are keys to women and girls' equality, economic opportunity, and development. They're key to their country's equality, economic opportunity, and development as well. One thing we've seen is what's called by some the shadow pandemic, the dimension of COVID-19 that has disproportionately affected women and girls, their access to health, their economic prospects, taking on more roles in the family scene and more vulnerable in work settings. And we'll look at some of those aspects of the shadow pandemic today. We'll have a few rounds of questions between the panelists and myself, and then we'll turn to questions that are submitted from those of you who are participating. There's a Q&A box probably at the bottom of your window for Zoom. Put questions in there at any time during the hour, and in the latter part of the session, we will move to your questions and try and get in as many as we can. Let me introduce our four panelists. First, Dr. Marianne Etiebet. She is Associate Vice President for Health Equity at Merck and the lead for Merck for Mothers. Merck for Mothers is a global initiative devoted to ending maternal mortality. Since 2011, it's resulted in healthy pregnancies and safe deliveries of over 13 million women in 50 countries. In the past, Dr. Etiebet has served as a senior technical advisor for the Institute of Human Virology in Nigeria, was a professor in the Division of Infectious Disease at University of Maryland School of Medicine. She has an MD and an MBA from Yale. Second, Dr. Stephanie Psaki, who in March joined the Department of Health and Human Services as Senior Advisor on Human Rights and Gender Equity in their division on global affairs. Previously, she was Director of the Population Council's Girl Innovation Research and Learning, or GIRL, Center. She's a social demographer looking at where gender, health, and education come together. She has a Ph.D. From Johns Hopkins Bloomberg School of Public Health in Women's Health and Demography, and a master's degree from the Harvard Chan School. Next, Dr. Angela Wakhweya. She recently came aboard at CARE to be Senior Director of Health, Equity, and Rights. She has over 2 decades of work across the development and public health sector in the United States and internationally. She has a doctorate in medicine from Makerere University Medical School in Kampala, Uganda. She also has a master's degree in health planning and financing from the London School of Economics and London School of Hygiene and Tropical Medicine. And then last and importantly, Lucy Wanjiku Njenga is a program officer for an NGO called Women for Global Fund. She leads their accountability work. Notably, she's the founder and executive coordinator of Positive Young Women Voices in Kenya, but more importantly was founder of Sauti Skika, the first network of adolescent and young people living with HIV in Kenya, back when she set it up in 2015. Diagnosed with HIV in 2012, she lost her son to HIV complications and has devoted her life to be an advocate, including taking part in the country coordinating mechanism of the Global Fund. So we have a great panel, and I'd like to ask a first question of each of you. Let me start with Dr. Psaki. What are the Biden administration's priorities on women's health in light of the challenges of the pandemic?
Thanks, Mark. And I just want to say thank you to Friends for all the work pulling this panel together. It's a big question, so I'm going to try to bucket it in a few different areas, but to pull it all together, I think one of the truths that this pandemic has illuminated for all of us is that all aspects of our lives are closely connected. So our health and well-being, our economic success, our human rights are linked. And that means that any response to address these complex challenges needs to also take into account those different pieces of our lives. So what that means is that if we're concerned about gender equality, we need to address the whole spectrum of risks and opportunities facing girls and women. So with that in mind, I'm going to share 4 different pieces of our strategy, but it's very broad and there are a lot of different pieces in here. So first, at HHS and really across the government, we are laser focused on combating COVID-19 in the US and around the world. And while we see signs of hope in the US, we also know that none of us are safe until all of us are safe. So this is really a global strategy that we're thinking about. So of course, that includes combating the direct effects of COVID-19. And as you probably have heard, earlier this week, President Biden reaffirmed his commitment to leading an international and coordinated vaccination effort. He announced that the US will donate 80 million vaccine doses, and this is in addition to $4 billion of support for COVAX and numerous other global efforts that are currently underway. And as we think about the direct effects of COVID, it's really important to keep in mind, and I'm sure we'll all touch on this in different ways, that in the US and around the world, women have played a central role in responding to the COVID pandemic, including as healthcare workers and other frontline workers, and as unpaid caregivers in their own families and in their communities. So the second piece of our strategy is that we know that other global health issues have unfortunately been somewhat neglected as we focus so much time and energy on COVID-19. And to be honest with you, within HHS, a great deal of our time and energy is being spent on COVID-19 right now. So we're trying to remind ourselves that we need to be able to work on multiple challenges simultaneously, because we know that the pandemic has worsened inequalities, that it threatens decades of hard-won gains on a range of health issues, from childhood immunization coverage to fighting HIV, TB, and malaria. And we also know that those secondary effects of COVID have been gendered. So data are incomplete, and this is really still emerging in so many parts of the world, but we've seen disruptions to reproductive health services, including access to contraception and antenatal care. We've seen a reduction in fertility-based births and increases in adverse maternal and neonatal outcomes in some countries. Early in the pandemic in particular, we saw drops in HIV testing for pregnant women. And we've seen some evidence of increases in violence against women and poor mental health. So as part of our COVID response and recovery strategy, the United States is taking steps to counter the erosion of major health achievements that preceded COVID-19 in these areas and other areas. And just to give an example, the American Rescue Plan designated $250 million to the President's Emergency Plan for AIDS Relief, or PEPFAR. And that money is being spent on ensuring continuity of care for people living with HIV, leveraging PEPFAR-supported health systems and infrastructure, reducing exposure of staff and HIV clients in healthcare settings to COVID-19, and providing flexible funding for PEPFAR programs so that they can optimally serve the HIV clients in areas that are highly affected by COVID-19. So the third piece of our strategy is focused on this priority for the Biden-Harris administration to re-engage on important issues that really cut across these immediate crises, COVID being one of them, but not the only one, and chronic challenges. And those include promoting gender equity, racial equity, and environmental justice. So the administration is committed to equity as a matter, of course, of human rights and justice, but also as a strategic imperative to reduce poverty, promote economic growth, health, political stability in the US and around the world. And to be very clear, when we talk about equity, that includes equal opportunity and treatment regardless of sexual orientation or gender identity. So achieving gender equity requires ensuring that women have access to healthcare, of course, and that they are able to access complete medical information, including with regard to sexual and reproductive health and rights. And we're working with our counterparts in the executive branch to implement the president's order revoking the Mexico City policy, resuming funding for UNFPA, and ensuring that adequate resources are being directed to support women's health globally. So looking forward, the president has also established the White House Gender Policy Council, which has the enormous task of developing a whole of government strategy for promoting gender equity and equality in the US around the world, which is quite an undertaking. And we are hard at work right now within HHS contributing to the development of that strategy alongside colleagues across the government. So the last piece I just want to quickly touch on of our strategy, and I think I'll have time to talk about it more a bit later, is one that really is at the core of the work that we do at HHS, and that is investing in primary healthcare as a foundation for health system strengthening. So in the context of COVID-19, it's clear that strong and resilient health systems play a critical role in our ability to prevent, detect, and respond to infectious disease threats. And of course, strong and sustainable primary healthcare safeguards public health longer term. It guards against these secondary effects that I mentioned earlier. It creates more resilient societies and is critical to addressing health disparities and advancing equity. So looking forward to talking more about that in a bit, but I'll pause there and hand over to my co-panelists.
A great place to start. Appreciate it, Dr. Psaki. Dr. Etiebet, could you speak to progress by Merck for Mothers on maternal health and in particular against maternal mortality? And in particular, when you're dealing with either long-standing epidemics like HIV, AIDS, TB, malaria, or the new pandemic, how's that a complicating factor?
No, thank you, Mark. And in the introduction, you actually started part of my response, which was around how, since 2011, Merck's commitment to helping end preventable maternal deaths has been able to improve, the quality of care and respectful services during pregnancy and childbirth for over 13 million women. And I think the key answer to that is around collaboration. This is, as Stephanie mentioned, is an issue that has multiple multi-sectoral drivers, so many points of intersectionality. And so our approach at Merck for Mothers is, how can we bring what may be the unique or complementary value of the private sector, whether it's around innovation, how can we also ensure that we are really close, to the consumer and making sure that women are the center of our work as well as the solutions that we are supporting, but also, a focus on health system strengthening as what we believe is going to be a key driver for sustained impact. And so as we've thought about, our progress over these last 10 years, it's been really heartening to see that including, collaborations that we've had with the US government, USAID, these health system multi-sectoral comprehensive approaches, like the one we engaged in over our Saving Mothers, Giving Life initiative in Zambia, Uganda, and Nigeria, we actually saw 44% reductions in maternal mortality in the districts that this partnership was active in. And I want to pull out one example, which I'm not sure everybody may be aware of. But one of the approaches that we did in Nigeria was making sure that women were no further than 2 hours, from a high quality facility. And, women don't care if that's a private facility or public facility. They just want to know it's a safe facility for them to give birth and for them to receive respectful care. And that was a key strategy. And in fact, in that state, maternal mortality rates reduced by about 60%. So we've seen, a health system strengthening approach can deliver on results. But we know when we look back in history, prior epidemics, that COVID, has the ability, to undo all of these gains and all of these progress. Before COVID, we knew that as a community, we would have to work twice as fast to get to the SDG targets that we've all set ourselves for 2030. During the Ebola pandemic, broader healthcare utilization was reduced by about 18%. But for maternal health services, it was larger. Facility-based deliveries dropped by about 28%. The modeling, has shown that, similar things can happen during COVID with devastating effects. But we actually don't have to look to the modeling because, as Stephanie has mentioned, we are already seeing drop-offs in utilization. And I will say that, whether it's the 40% drops-offs in, facility-based care or skilled birth attendant rates, it's a two-step process that we need to be cognizant of, both making sure that there continues to be effective delivery of services, but also that there continues to be safe uptake of services. We have to think about the demand side, of what's happening during the COVID pandemic and how people are making decisions about the behaviors that they are going to engage in around health seeking. And so, we have learned so much from our partners, over 100 partners in 50 countries, as you mentioned. And I'd actually like to take a moment to thank them, for all the work that they've done during this really, really challenging time. I mean, I will say that they have actually not just managed to continue to serve their clients, but they've actually increased what they're doing, reaching more clients with more services. I'd like to highlight maybe kind of 4 big takeaways that, from the experience we've had during COVID. One is the need for integrated services. It's hard enough for people to get to one appointment, but one appointment during COVID. We can't expect them to go to a different place for their prenatal care, for their childhood immunizations, for their HIV testing, for their primary care services. That's just, we can't expect that anymore. And COVID has just shown how difficult that's going to continue to be. So how do we think about integrated care services, integrated care networks? How do we think about reducing the social determinants of health barriers? Transport, became very obvious what a barrier that was during COVID. But that barrier that was, we all witnessed during COVID often has been invisible and silent, before COVID. And so I think we need to continue to make sure that not just the issues that have been illuminated by COVID remain top of mind, but the solutions that local communities are creating to solve for them, we actually continue them, post the pandemic. The other point is around private sector providers. We know that women are seeking, critical maternal health and reproductive health care services from local private providers, 40 to 60% in many of these low-income geographies that, that we're working in. And they have been critical in augmenting government responses during COVID and increasing, the supply, of service delivery in these communities. We've also seen that, when we as a global health community, are not there, there's more space, for local leadership and inclusion of multi-sectoral actors in these geographies, to work on what's needed specifically. The third thing is around digital technology. And we've seen the proliferation of digital technology to enable not just information movement, but also care delivery. We need to make sure that the digital divide doesn't actually exacerbate the inequalities that we already see in maternal health, as we think about, what happens post-COVID. And then the last point I want to make, I think this is also related to what Stephanie mentioned about how our response, actually has to be intersectional. We've all talked about how COVID has had a devastating impact on lives, as well as livelihoods. But I do believe that with intentionality, our responses can not just save lives, but they can actually strengthen livelihoods by investing in local, community-based organizations, local social entrepreneurs, local private providers, local innovators. These are the engines of local economy. And if we intentionally make them part of our response, hopefully, our investments will have a multiplier effect.
Wonderful. Rich. I'd like to move to Lucy Wanjiku Njenga next. You're a founder and a leader of civil society organizations that are devoted to giving voice to women on health, and you're a person living with HIV. Can you speak to the role of communities in improving access to women's and maternal health care?
Thank you, Mark. I'm really happy to hear my fellow panelists really going at least into details of what I want to speak on. So it shows we're speaking from the same, we're speaking in the same voice. So really excited about that. Communities are key and center of our work at all levels, and more so in women's health, to ensure that there is access, availability, and affordability. My growth as a person and journey as an activist and leader has been inspired by my community of strong, resilient women and girls in all our diversities. And women in their individual capacity organization networks have done their very best to ensure that the gains made were not lost in the context of COVID-19 pandemic. But without a broader system, it has not been enough. I want to highlight 3 areas where women in communities have played a key role to improve access to women's and maternal health care. 1, sexual and reproductive rights and access to services. It still remains a core issue for us. Menstrual periods do not know pandemics and come monthly, and so we still need menstrual products. We still need antenatal, maternity, and postpartum healthcare services, even in the middle of a lockdown, as well as contraceptives and our treatment for HIV, TB, and malaria, which is essential in our health. Women in communities have ensured that there is access to these services and made referrals, as well as advocated for funds to address the barriers and inequalities that were amplified by COVID-19. The second big area has been around intimate partner violence and femicide, where globally we have seen more cases and deaths as girls and women are forced to stay locked up with their abusers. And my colleague in the panel are related to this. So there's a huge gap. Not enough was being done before, and COVID just made this even worse. Women organizations have filled the gap by opening up their homes and offices as makeshift safe houses, and safe houses have opened doors to more women than ever before. Even with all this effort put in, there's so much that is needed from our partners and governments. I believe being in the community, working with a community-based organization, that each community-based organization, which is the first contact with the woman, needs to have support to run a safe house or have connections with a safe house where women and girls can be referred. In our case, we had lesbian, bisexual, and queer women who are facing forced marriages once their families confirm their sexual identities, corrective rape, and abandonment. Sex workers faced hardship with getting work and thus could barely sustain their families and households when faced with needs for shelter. There was not enough for everyone. Communities were there, yes, for them providing safe spaces and food baskets. Though we know governments and donor partners need to support communities who are established to scale up safe spaces and safe houses to enable them to continue to support women and girls. And lastly, ensuring access to medication, because shortages of medication due to the abrupt nature of everything that has happened and the lockdowns was really seen and fueled during these times of COVID. People living with HIV at most times relied on the services of community organizations, peer educators, mentor mothers, and healthcare volunteers to ensure they got their medication, as well as food baskets. Without civil society playing the pivotal role and standing in the gap for our people, a lot of gains would have been lost. Here in Kenya, we have a serious stockout of nevirapine prophylaxis for children, with no clear solution being given to mothers. And just from a meeting today that I thought I would get a clear go-ahead, but I did not get it. Mothers have tried sharing both prevention and treatment dosage that they have, as this is the best that we do for communities and as communities for each other. We're also being told, though not directly, that this is not a good time to get pregnant for women living with HIV. So you can imagine the anxiety that is surrounding the whole scenario for a woman living with HIV in Kenya. And we've had our advocates take it to social media with a report that even WHO heard of it first from a tweet of one of our colleagues. We still have ARVs stuck at the port of Mombasa when people living with HIV are getting 2 weeks stock or 1 week, and sometimes none. Our advocacy is being heard. However, empty words can only do so much for us as Kenyans living with HIV. Lastly, is to say we cannot deny the role of communities to try and ensure no one was left behind and is being left behind. More resources are needed and should be invested here where it matters most. Thank you, Mark.
Thanks a lot. Dr. Wakhweya, how has COVID-19 affected the maternal and child health in countries where CARE operates? Do you have any insights from CARE's programs and partnerships?
Absolutely. Thank you very much, Mark, and thank you to my fellow panelists. I will start off with 3 stories, or 4 stories, quick stories to build on the foundation that Lucy has given in terms of what's happening on the ground, as we at CARE also have our eyes on the ground. One story is a girl, who at the beginning of the pandemic did not go for a screening in relation to growth in her groin area, and it ended up being colorectal cancer, and she ended up with a colostomy. Or a second case of a mother antenatal, went to a private clinic, had not been assessed for hypertension, and ended up having preeclampsia and eclampsia and died, leaving behind a live child. Given that she could have gone for antenatal care and been able to assess whether she had hypertension or not. Or a couple of girls, sisters, who, because their father during the pandemic was saying to her, go out and get food, and she ended up getting married to a man twice her age. Or lastly, the mother during lockdown, where she was in, as Lucy mentioned, a pandemic does not know whether menstrual periods are going to stop, they're going to continue, or that a woman is going to give birth. And here she was during lockdown, not being allowed to go to the antenatal clinic to give birth, and literally was giving birth on the street because there was no transport during lockdown. So these are just snippets of a whole constellation of stories of girls and women being affected during the COVID-19 pandemic. At CARE, it's a 75-year-old organization. We just celebrated our 75th anniversary, working with communities and other nonprofits, the private sector and the public sector for a very long time. Our mission is to work around the globe to save lives, defeat poverty, and achieve social justice. Our vision is to seek a world of hope, inclusion, and social justice, and to overcome poverty for all people so they may live with dignity and security. But the focus of our work is on girls and women. They are the center, because we know that if you lift a girl in terms of both her education and economic ability, the life of her children, herself, and her family and her community will grow. So we have a very laser focus on girls and women at CARE. And one of our main thrusts in terms of how we hope that not only the COVID-19 pandemic can be mitigated, is through a localization process that we are leaning into with intensity over the next decade. We have done so in the past, and we're going to even lean into it more. We have a major project in Bihar, India, even now as there's the conflagration of COVID-19 in India, building on the work that we've done in Bihar over 10 years through a large private sector donation. We have a project that focused on, one, the health system strengthening, working very closely with the Ministry of Health so that when a pandemic such as COVID-19 comes, we are ready for it. Working in terms of digitalization, Marianne mentioned digitalization. If anything has taught us that we need to digitalize fast, it's the COVID-19 pandemic. We already had started that with our Bihar project in terms of digitalizing tools for frontline health workers all the way from the village to the primary healthcare facility to the government. We're pushing ahead with that, and I'm going to expand on that work. In the Bihar project, we work with community health workers or frontline health workers. And the COVID-19 pandemic has shown us that we absolutely must focus on community health workers and frontline health workers. So this localization in terms of working with the local Ministry of Health, but also working with other partners locally is potentially the way out of this pandemic. Because even with the COVID-19 pandemic requiring vaccines, we can manufacture the vaccine, but how do we get it down to the ground? We call it the stomach to arm. That is a major gap. We can have vaccines, we can supply them, we can get them to the airport, but how do you get them from the airport into the arm of an individual? That's where organizations like CARE come in, and our strategy of who do we work with? We work with the public sector, as I mentioned, the Ministry of Health, and also the Biden administration and other governments across the world. The second way is working with nonprofits, our fellow international non-governmental organizations, but very critically, working with local civil society organizations and advocacy partners like the organizations that Lucy represents. And then thirdly, working with academic partners. We have a whole slew of academic partners that we work with in terms of getting the lessons learned and bringing these to bear in terms of the publications and conferences we attend. And then with the private sector, working with corporations and foundations to fund the work that we do. We need more funds to do the work, but we do that. But again, leaning into working with the fifth side, the community, and also local civil society organizations that I mentioned. So I'll conclude by just saying that CARE USA and our CARE International family, working in over 100 countries globally, are prepared to work with the public sector to do our work with academic institutions, the community and local civil society organizations, leaning into localization where we want to resource and build up and strengthen local civil society, because at the end of the day, they're the ones closest to the mother and child who's impacted by COVID-19. Thank you.
Thank you very much. A number of you have touched on public-private civic partnerships. Do any of you want to add a further observation about how they're, the partnerships that are multi-stakeholder are particularly useful for women's and maternal health? Do they, leavening public sector work? What are some best practices? Do any of you want to elaborate, especially hearing some of your colleagues very briefly in an interchange between the four of you? For instance, Dr. Etiebet.
I'm happy to go first, but definitely as an exchange. I think the first thing I'd like to say, and this pulls on, and Angela, if I can call you Angela, her point around a localization strategy. I think when we use the term private sector, people's minds automatically go to global multinational corporations. I think we need to remember that there is a vibrant local private sector in many of these countries that we are working in, serving. And we need to reframe our understanding of private sector to actually focus on that. That's the sector that's going to, bring in more resources, bring in sustainable business models, allow this work, to scale and replicate and sustain, support local economies, create jobs for women. This is, I think, where we need to focus our work and really have that be a localization strategy. And then the other thing I'd like to mention about private sector, it's not just the private sector within the health sector. We need to be thinking about non-health private actors. We've just talked about digital. There are so many determinants of women and children's health that are outside health. How do we intentionally bring those investments, companies to this issue?
That's great. Ms. Wanjiku, Njenga, do you have anything that you wanted to add about partnerships, Global Fund, and other things that you've seen?
I believe that partnerships are very important, and where we have seen facilities partnering with women organizations or with civil society, we've seen a lot of change, especially like the Mentor Mother program, where we have a mentor mother who's a woman living with HIV at the facility for other women living with HIV. So it's really worked wonders. And it also brings out the aspect of ownership for us as communities. We are owning the programs, we are owning the activities, and we can scale them up or ensure that they're sustainable. And this is important. And I heard of Angela mentioning thinking, and also I think Stephanie thinking of, and I think also Marianne, localizing the efforts. That is the missing link that has been missing. And who is best to support a woman in her rural area or in her community other than another woman who they have respect for and has authority in this community? And it's very important for us to invest more and create these relationships that will create a ripple effect by the end of the day and ensure that the gains we want are met.
Dr. Wakhweya or Dr. Psaki, do you have any things you'd like to add on partnerships, multi-stakeholderism, best practices?
Yes, let me dive in, and I would definitely love, Stephanie, your insights on this too. And just kind of pinging off of what Mary Ann is saying about corporations and the private sector. You're absolutely right in terms of we need to reframe the debate. But if I dive into the private sector as it's traditionally known, whether it is large multisectoral, multinational companies, or even the private sector that's growing in some of the global South, like in Asia and Africa, in South America, they're billionaires, they're billion-dollar companies even there. So we definitely need to tap into them more. We have many partners as CARE who fund our work, and we need those partners. But by far, the largest funder of health services is the public sector. Even now, whether it is in the global South, it is the ministries of health. They're by far the largest funder. That's why we work with them and try to improve the quality of care that they provide, because they will never go away. But private institutions, non-governmental organizations, we come alongside them. And that's why, back to your question, Mark, that partnership is extremely vital. Just like the United States is the largest funder of health, aid globally. It's the largest development funder and continues to grow. It is impossible to take the United States out of the equation. So the United States needs to be there. So given all these funding streams, whether from the private sector and public sector, as Lucy mentioned, we have known at CARE that and have been pushing this localization concept. We even have a program within CARE called Global to Local, where we are pushing on this localization concept, and we're going to accelerate it in a big way. Because as Lucy mentioned, when you talk about those community-based organizations and national non-governmental organizations, they're the ones who are closest to the ground. But oftentimes they need working with us as international NGOs who have, let's say, received large funding from the US government and know the ins and out of that. And so we are willing partner to come alongside those local organizations and give them those skill set and build those up so that they're able to absorb those funds and really make a difference in the lives of women and girls, especially in rural areas. Thank you.
Dr. Psaki, do you have anything to add in this area?
I'll just add a couple of quick points to what the co-panelists have said. One is that I think this issue really is a priority for the Biden-Harris administration. There's a lot of discussion happening within the government about how we can build more robust and effective partnerships across different agencies. And a big part of that includes public-private partnerships. I think when we think about partnerships, there's different forms. And so PEPFAR has, made a huge effort to work closely with civil society organizations across different countries, and also involve CSOs in the decision-making process at the country level. As we, one of the questions that I'm grappling with is also in the policy-making process at the national level in the US, but also as we think about global policy and priorities. How do we make it easier for a diversity of voices in terms of partnerships to provide input in that process? So, there are a lot of rules about partnerships in government that are meant to structure them in a way that is open and inclusive, but I think what ends up happening is that it creates a high bar for participation, and it requires, having staff who focus full-time on government affairs and things like that. So I'm really thinking, and I think many other colleagues in government are thinking about how can we figure out easier lift ways for people to share input, and really open to your thoughts on that as well. The other thing I just want to mention very quickly is the importance of multilateral partnerships, which is again, a high priority for the Biden-Harris administration. And in OGA in particular, we're very focused on rebuilding our relationship with the World Health Organization and with UN agencies more broadly. This is a key addition to the bilateral partnerships to make sure that we're making decisions globally that apply in different settings.
Great. In order to get to our questions from all the folks who are tuned in, I just want to ask one question sort of all of you, if any of you want to chime in. Is there one particular challenge for women's and maternal health, whether it's health systems or exactly how to implement and define health equity, that you'd like to point out? And at the risk of this being like the speed round of a game show, just what is it and why is that one thing important? Perhaps Dr. Etiebet first.
I think the one thing is around broader societal equity. Maternal health really is that conflagration that reflects, broader societal inequity, whether it's gender inequality, racial inequality here in the US, economic inequality, ethnic inequality. And so making sure that the way that we work is also something that helps to dismantle, those systemic structures of inequality. I think that if we manage to crack that nut, we may see more progress and better quality of lives for women and girls around the world.
Great. Do any of the other three of you have a challenge that you just want to shine a light on that you haven't already?
I'll just add, I think this has come up, but this issue of health system strengthening and just, especially in the midst of a global health crisis, how do we balance the crisis response with longer term investments and capacity sharing? And I think for the US government and something that we talk about in the Office of Global Affairs is really shifting. I think this is reflective of how the CDC works, for example, shifting from this traditional model of engagement between the US and other countries to a model of really shared capacity, shared partnership, learning from what has been demonstrated in other settings to apply it in the US and vice versa, so that next time there's a global pandemic, which hopefully won't be for a long time, things look very different in terms of structures of power and how we respond.
Lucy or Angela, if I may, coming to know you, any challenge you'd want to just put on the table before we turn to our audience?
Absolutely, and I would love to hear Lucy's as well. One thing is to echo also what Stephanie has said about health system strengthening. At CARE, as the Right to Health lead for CARE International, CARE USA sees two goalposts: health system strengthening and public health preparedness and response. Yes, the humanitarian emergencies will happen, but she's absolutely right. And that's the pillars of our strategy, that you got to strengthen the health system so they're resilient before a shock to the system, during the shock to the system, and after. But one fundamental piece that I feel that we haven't done enough of is that governments the world over need to recognize that the basic rights of a girl and a woman are the basic rights to protect her through policy and legislation. And the very people who write those policies and legislation need to be women, Over to you, Lucy.
Lucy, anything?
I love that, Angela. I do. And you're speaking right from my mind. And I'm thinking with the experience I have being in the Kenya Coordinating Mechanism in the Global Fund and looking at the TRP comments that come through, we still haven't hacked addressing gender inequalities that women are facing in countries. Our activities tend to be vague, and I think there just needs to be more coming from countries that we want to see, because women's health is not just the MTCT. Lucy is all rounded, and it's not only tied to the life that I give and or there are many needs that a woman has, and I think it's very important for us to consider this as governments. And I'm going after countries, because when you talk to Global Fund, the issue is your country gets to decide. Your country is not deciding on this. And it's not that us as women and advocates in countries are not speaking of what it is that we need. We are, it's just that we're not being heard, and what we're saying is not being implemented. So I think that's where the disconnect is coming. We end up having projects that are not gender transformative. Yeah, thank you.
Great. Well, let's turn to some questions from other participants in this Zoom conversation. Manaz Harrison of Last Mile for D notes that a lot of the conversation about the impact of COVID-19 centers on services provided outside of the home and problems that occur outside of the home. Is enough attention being paid on those things that are taking place inside the home? Domestic violence, female genital mutilation, child marriage, perhaps spiking because of the lockdowns. Would any one of you want to take that on? Anything about, is this something, Stephanie, that has seized the administration on, those problems like FGM, gender-based violence?
Yeah, I think it's a great question. And I think, what I would say in part is, I think, unfortunately, what we have seen, certainly in the US, and I think in many parts of the world, is that we were so unprepared for COVID and the effects of COVID that it really has thrown us off in a lot of issues, including the effects on some of these other issues that are high priorities and hugely important. And we need to really recommit to focusing on those areas. At the same time, there are a lot of ongoing programs and investments that are focusing on those issues and have managed to carry on. And I'm sure CARE has managed to pull that off, for example. So have managed to carry on and have kind of been under the radar as everyone has been so focused on COVID-19. So I would say that in a lot of ways, COVID has exacerbated and highlighted the risks to many of these populations of experiencing these outcomes, but it hasn't fundamentally changed the structures in terms of the populations who are at highest risk and even the interventions that are likely to be most effective. I'm sure others have thoughts.
Before I move to another question, do any of the rest of you have a burning comment you'd like to add on Manas's good question? Okay. Another question we have is from Ben Plumley in California. As the primary purchaser of healthcare around the world is typically the patient themselves, how do we make maternal and child services more affordable and accessible to girls and young women in particular? Some of you have talked about private sector actors in that picture too.
I mean, I can add, to some of the themes that have emerged. And, one of the things I think that COVID, has also done is kind of knocked all of our work around advancing universal healthcare coverage, off the kind of top of folks' consciousness. And I think when you look at that construct, where it's about not just access and affordability, but also about quality, because we know up to 60% of the deaths are actually more from a lack of quality than a lack of access. But then, that affordability aspect. And some of the work that Merck from others is doing is ensuring that universal healthcare financing schemes, that are being administered by governments actually subsidize care at high quality local private providers. So women are able to go to seek care, where it makes the best sense for them, where they know it's high quality, and where affordability is enabled through linkage, to universal healthcare coverage. So I think that there are lots of different ways that, to achieve that, including, Angela, you made the point about resource constraints. We are in a really actually dangerous time where resources that had been had been focused on maternal and reproductive health are no longer available. So where are they going to come from? And I think a big place that they can come from are from private sector investments, not philanthropy, but thinking about investments that can have not just a financial return on investment, but a social return on investment. And I think those are the ways that when we are able to scale these solutions, that they don't not only reach more people, but they can become more affordable, especially if we are targeting those investments in those solutions, which are really addressing the needs of local populations and are fit for purpose and are affordable.
Just if I can chime in real quick on that, Mark, that's a great question. And we know that maternal health is inextricably linked with her economic security and the economic power she has, and also her decision-making power. Because you might have the economic security, but you don't have the decision-making power, deciding to go to the hospital, deciding to give the money, to have the money to be able to go and pay for your child or for yourself. So in most developing countries, there's hardly a safety net. There's not even universal health coverage. There's not even a private health insurance scheme to even talk about. So we've got a lot of work to do in terms of providing that safety net for women, but also building up the private sector. And CARE is working with women's groups, savings schemes, and bringing about some social entrepreneur programs so that women, as they gather together, can try and recover from this economic shock of COVID-19 and be able to improve the economic security. Because at the end of the day, without that resource that she would have as a woman, she cannot, and her decision-making power and her agency, it'll be very difficult to achieve the maternal health that we would like. Thank you.
Another question is, we've looked at health equity so far, and it's been acutely focused in terms of vaccines recently. But if you're to think about health equity more broadly, what's necessary, and how important is that health systems element that multiple ones of you had? Is more general health equity something that depends on health systems if you look at it in terms of women and mothers? And who's good among these actors that we've been talking about at developing health systems in partnership? Anybody want to elaborate on equity in health systems?
I would say it's more than health systems. It has to be a whole of societal approach. And to Stephanie's point, we need to do better about measuring the impact, of these multi-sectoral collaborations, including public-private partnerships, and identifying, those barriers and challenges, and sharing them and making them visible, so the next partnership doesn't have to duplicate them. We can leapfrog, over the things that we've learned. And I come back to the partnership role because I don't think that we can, as a society, as a global health community, achieve equity unless we are all bringing the best of what we have to bear to the issue. And that means collaboration and partnership.
Lucy's spoken to civil society and affected populations' voice. How about community health workers? Many people, when they hear health systems, they think of bureaucracies, but when it comes right down to it, health systems, perhaps in most valuable form means community health workers. Is that a key to women's and maternal health and to equity?
It definitely is very key, Mark, but this is where I find or see list of resources being invested in, and it beats the purpose of having these people building the health system on their backs, and yet not for them not to feel appreciated and to feel they are part of something larger than themselves that is, by the end of the day, ensuring that there's access and there's equity when it comes to access to health care and services. So there's lots of investments that needs to go towards that, and we need to see more partners coming up and supporting this key area where peer educators and healthcare volunteers are feeling appreciated and feel rewarded, and it's something we even aspire to do, Yeah.
Yes, I'm glad you spoke to that because you're absolutely right. Frontline health workers and community health workers are 70% of whom are women, by the way. 70% of them are women. And this is not only clinical, but also the non-clinical frontline health workers, the boots on the ground, the ones who go into the villages, whom we also work very closely with. We advocate absolutely and put into the stipends that they need, the childcare that they need, the PPE that they need, the other protections that they need. Is it a backpack? Is it an umbrella? Is it, so you're absolutely right, Lucy, that we cannot build the health system. If you talk about health system strengthening, we do mean Ministry of Health, we mean digital, we mean primary health care, but we also mean the people who man the primary healthcare centers, but also the people who go out into the field. And we must provide them also adequate resources, including stipends and the childcare that they need and other amenities. You're absolutely right. I concur with that.
As we wrap up, Dr. Psaki, did you have anything you wanted to say about community health workers being the first to have brought up health systems that are resilient?
Yeah, I'm so glad these points have been made, and just to pull together this full circle here is the inequity issues when it comes to community health workers. There's a fairly large gender pay gap broadly in the health and care workforce, and as I think Lucy mentioned, community health workers in particular, and the challenge that we are building this vision of equal access to healthcare on the backs of mostly women of color, many of whom are unpaid. So I think we need to really keep in mind this picture of how are we building out this vision and the need to invest resources in things that we say are valuable. I think that's necessary in order to achieve this health equity vision.
Great. Well, it's been a rich conversation. We could have talked for 3 hours, and I appreciate your participation in this. It seems that there are some themes, problems exacerbated by COVID-19, but also problems brought into clearer focus by COVID-19. And it's for us to, partnering with those, on the ground to try and address those women and women's and maternal health issues. And a lot of you touched on local actors, local civil society. Dr. Etiebet, about those local private actors, not just the multinational corporations, and some take the form of social enterprises. I want to urge those who've tuned in for this that if you want to find out about future events that Friends of the Global Fight Against AIDS, Tuberculosis, and Malaria is hosting or co-hosting, you can follow us on Twitter at the Global Fight, all one word, or sign up for our newsletter, which is easily done on our website, www.theglobalfight.org. This has been a wonderful complementary group from different vantage points and sectors, but quite a consensus on the importance of women's health and women's empowerment, not just for them, but for a thriving and more equitable world. With that, I'll close this out with my thanks.
Thank you.